slight disruption. It's due to some internet connectivity issues that we are having right now. Just to finish the practical information part, please be informed that this session is recorded and it will be made available on YouTube. There will be feedback survey that will be emailed to you, and we encourage you to participate and come with suggestions on how to improve and what topics to address in the future. This is just to show you that in case you have missed on earlier webinars in the past, they are available on YouTube, and you just write Botswana-Rutgers Partnership for Health to access them. And we have 7 of them from before. We also do have an updated website from the Ministry of Health that updates on issues relating to COVID-19 and also includes guidelines that have been published. So to start, I would like to introduce our first speaker, Dr. Chobe, who is a public health practitioner. He has been working on TB and TB-related issues for the past 10 years. He has worked as a multi-drug resistance TB national coordinator and also TB program manager. He's currently also doing his last year in clinical epidemiology at the University of Pennsylvania in the United States. And he will talk to us about the Chobe district COVID-19 response. Dr. Chobe, the floor is yours.
Good afternoon, everyone. I'm here to share the experience of COVID response in the Chobe district. This will be the outline of my presentation. We'll look at the background, look at how we are coordinating all COVID-19 activities, look a bit at the screening at points of entry or ports of entry, laboratory testing, surveillance, infection control, information dissemination, logistics, and we'll also look at the challenges that we have had and also come to the conclusion. For those that don't know Chobe, Chobe is a district that shares a border with 3 countries. I think it's a very special area because even though it's a small district, it has 7 ports of entry, including an international airport. According to the 2011 census, the population was 23,347. It has 1 primary hospital, 5 clinics, and 6 health posts. It's Botswana's tourism hub. So just like the whole country did respond to COVID, the district also responded in February 2020 following the first case of COVID that was reported in China in December 2019. We activated our rapid response team in February 2020, also had the district disaster management committee meeting, and then the formation of the District Emergency Operations Center or COVID District Emergency Operations Center. The initial focus at the beginning was really at the ports of entry, which included the Kasane International Airport. As you may remember, we also started with mandatory quarantine for international travelers on March 25, 2020. So looking at how we're coordinating activities at the district level, we have what we call the District Emergency Operations Center, as I earlier alluded, which is chaired by the district commissioner. The membership includes all government department heads, non-governmental and parastatal organizations, the business community, like Business Botswana. There is also the Pandamatenga Farmers Association. And this body reports to the National Emergency Operations Center weekly. We also have other bodies at a lower level. At the village level, we have a village emergency operations center, which is usually chaired by the school heads. And then, of course, since it's a health issue, most of the technical leadership is provided by the DHMT. So looking at screening at ports of entry, we currently have 4 ports of entry that are functional. The other 3 are closed. We have Ngoma, which is the border to Namibia, Kazungula Ferry, which is a border with Zambia, Kazungula Road, which is a border with Zimbabwe, and the temporary bridge that is a border between Botswana and Zambia. Since the 25th of March, we have been screening. Everybody who comes into the country has been screened. And also because we have a bilateral bridge project, which is a project between Zambia and Botswana. There are staff who, the project could not be stopped because it's working on a tight deadline. It has staff who are coming from the Zambian side. I want you to note this because I'll go a bit deep into it as we move forward. We have a bridge project that involves workers from Zambia and Botswana who meet at the project. So that has implications on potential spread of the disease. Initially, we had returning Botswana and returning residents as the most people were coming in, but since April, May, it has been mainly truck drivers who are coming to the country, some coming to Botswana and some on transit to South Africa. You remember that we do testing of all the truck drivers. When they come into the country, they are tested before they can proceed. And that means they have to be swabbed and also wait for results. So we currently have 2 places that we have identified where these trucks park while they're waiting for results. We have Weybridge and we also have Pandamatenga. Each one of them can take 40 trucks at a time. Sometimes we may go to 42, 44, depending on the size of the trucks, but it's mostly around 40 per the holding area. The Weybridge area has toilet facilities and showers. However, it comes at a cost. Using a toilet, you pay 2 pula, and the shower is costs 13 pula. And currently, the drivers have to pay for themselves, and they've been complaining that they cannot afford, and the government should pay since is the one that is holding them. There is also catering facilities available where the drivers have to buy food. Now, another business in Pandamatenga has provided us a space that can hold also 40 trucks. And fortunately for this one, there are no issues like Weybridge. They provide free toilets and showers. They provide free Wi-Fi, I think that is luxury. And they also provide free food for the truckers. Looking at the number of trucks that are coming into the country, I have to say that pre-COVID era, we could take up to 160 trucks per day from the 3 borders, but now we are limited by the space that we have, which means that we can only take around 80 trucks a day, and most of this are on transit. So as on the 9th of June, we had 88 trucks coming in, and of those 88, 73 were on transit to South Africa. I think compared to other districts, you can see that despite us being a very small district, we are like number 4 in the country, and probably would even be the highest or maybe second after Gaborone if it was not for the limit of the holding places. I'm happy to say that we are able to test locally. We have ACHAP, who is one of the government stakeholders who's providing the swabbing at the ports of entry. They do it at the Weybridge. And then testing is done at the primary hospital that I earlier talked about. And the current turnaround time is 24 hours. Of course, a test takes up to 6 hours. And We, however, just do one cycle per day because the test capacity at a time, the machine can do 90 tests. And if we're working 24 hours, we could do around 360 to 450. That is around 4 to 5 cycles of 90. And then for all the positive cases, we don't confirm. However, we send to the National Health Lab for confirmation. Since we started this exercise and test locally, we have swabbed 1,789 individuals, and all of them have been processed, and we had 1,784 negative and 5 positive at Kasande Primary Hospital, which I'm happy to say were also confirmed at the National Health Lab. As of the 10th or the 9th, we had reported 11 cases. Remember that the 5 that I talked about in the earlier slide does not include the ones that were tested at the National Health Lab before we started testing within the district. As of the 9th, we had 11 confirmed cases, but that figure has since changed. It's now 12. So we have had 12 cases since we started testing both at our district and also at the National Health Lab. Chobe has reported 12 confirmed cases. And of all the 12, all are imported cases and they have since been repatriated. We have had more than 58,000 arrivals since February 2020. And like I said, we remember that before the guideline was not to test everyone. Things have been evolving, and that is why there is a difference between the number of arrivals and the number tested. We also have a team of contact tracers that is led by the district community health nurse. We also have TOTs that have been trained on contact tracing. Mainly this comprises of health education officers and health education technicians. We are planning to train around 300 participants and community volunteers within the next 2 weeks, because taking the worst case scenario, the district needs around 300 contact tracers. As far as quarantine facilities are concerned, we have since the beginning, since we started mandatory quarantine for all people coming to the country, we have used Travel Lodge, Bush Lodge, Big Five, and Chobe Marina. And the number of people that we have quarantined so far is 317 that have been discharged and 27 that are currently on quarantine. And the only quarantine center that is currently working is Chobe Marina, which has 27 individuals currently on quarantine. Out of the 27, we expect the last one to leave next week, Saturday. As far as contact tracing is concerned, every time we have a case, we have also, tested. Of course, the officers who are working at the border have not been true contacts, but however, as a precaution, we undertook an exercise to test all the officers that are working at the border. We have so far tested 312 officers, which include police officers, the revenue service, immigration, port health, and all the clearing agents that work at the 3 borders. And I'm happy to say that so far we have not reported any local case. Ignore that suspect. And the other thing, we have, as a district, realized that there is still potential for introduction of the disease into the community, especially through commercial sex workers. The truck drivers, when they're at the holding places, there is the police and the Botswana Defense Force who look at make sure that they do not interact with the community and go into shops. However, we know that that is not watertight. Sometimes some commercial sex workers are able to sneak in, or the truck drivers are able to sneak out. And we also have the bridge project, which, as Aila said, I will keep on talking about it because it has about 117 Botswana who are staying in Kazungula and Kasane area on the Botswana side. And we have about 500 workers who are coming from the Zambia side. And I have to say that recently, some of the cases that we have reported from the truck drivers are people who stay in Kazungula and Livingston on the Zambia side, and who some were traveling and had been spending time with their families. So there's a chance that there will be importation of the disease through the bridge project. The other issue that we also have is that, you know, that area has a lot of illegal immigrants, especially from the Zimbabwean side. What we have done is that we provide mandatory screening and testing of all illegal immigrants before we send them back. As far as infection control is concerned, of course, the main emphasis is on rational use of PPEs to prevent stockouts. We also have the police and the BDF who make sure that the community adhere to social distancing and use of cloth mask protocols. And we also have weekly disinfection of offices at the border. And every time there's a confirmed case, we also disinfect. And we also disinfect rooms that have been occupied by individuals on quarantine upon discharge. We also have a place where we do the swabbing. We also disinfect it regularly. And also sometimes we have instances where somebody drives a truck up to the border and they have to swap drivers. We also disinfect before the truck can be used by a driver from our side. Isolation centers, I have to be honest and accept that we currently do not have capacity for isolation of potential sick clients should we have. Like I said, all the 12 cases that have been reported at the district have all been repatriated. And the only isolation rooms that we have currently is one room at Kasane International Airport. It's not really a permanent isolation room. It's more of a temporary room while they're waiting for referring to a more permanent place. We also have one room at Kasane Primary Hospital. And then we also have 2 beds at Weybridge. Actually, it's just beds with no equipment. So I have to say that there's no appropriate equipment for ICU should we have, should we get to that point. However, I have to say that we are looking for funds. We have identified a place at Pandamatenga, which is a community hall. We have designed a plan. Some engineers came and looked at it and came up with a plan which needs funding. Once we get the funding, I think it will be good to take about 100 ICU beds. 100 beds. As far as information dissemination to the community is concerned, we initially started with sensitizing the community leaders. We could not hold khotla meetings because of social distancing. So we just had a small group of community leaders and village extension teams, which were supposed to now pass the message to the community. So far, we have reached more than 7,000 individuals through small group sensitization at business, at government offices, businesses, and also schools. Also take into account that we can have large group gatherings. We used overhead loudspeakers to pass sensitization messages. We have also provided IEC materials at offices, shops, and are also available at all health facilities. As far as logistics are concerned, I have to say that initially it was the Minister of Health that was doing all the procurement, but now the coordination has since shifted to the Office of the District Commissioner. The major challenge that we have had is shortage of non-contact thermometers, which I have to say, just this afternoon I was given about 25, which is good news. We have a transport that is availed. We have an ambulance that is used to transport suspects, and also we have one vehicle that transports hotel staff to the border, and we also have 4 vehicles which are on standby to send samples for confirmation. So anytime we have a positive, there's always a car that is ready to take off to Gaborone for confirmation, so that we act immediately. The challenges that we have had is, like I said earlier, is the holding place for trucks. The Kazungula ferry border usually receives more than 100 trucks a day. And the Kazungula Road, which is the Zimbabwe side, is supposed to receive around 60 trucks a day. In Goma, it's okay, they receive around 10 per day, but now the number is limited, which means that there's been a backlog of trucks on the other side, especially the Zambia side. Now, this has caused truckers to divert and use our competing route, which is the Beit Bridge in Zimbabwe. So recently, we because of the lack of space to get more trucks, which may have serious implications for the country, because we get a lot of revenue when these trucks transit through the country. Another challenge is the isolation facility. As I earlier said, really we don't have an isolation facility as we speak. Then the Kazungula Bridge project, which I think I have talked about extensively, there's an interaction of people from Botswana and the Zambia side, which still remains a potential source of introducing the disease into the district. I have to say that the reason why I say introducing the disease into the district is we really don't want Chobe to have an outbreak of COVID, given its importance to the country. Like I said, it's a tourism hub. Then the other issue that recently came is that the government has said that anybody who comes into the country and goes into quarantine should pay 50%. And we have had individuals who have come out and say they cannot afford to pay the 50%. And we have been stuck and not know, because the hotel will not allow those individuals to go into the hotel without paying the 50% in advance. So it's really a big issue that still remains. And then of course the commercial sex workers, like I said, they still, serve as a potential to bring COVID into the. Now, in conclusion, I think as Chobe, we have really generally been successful, but challenges still remain, like I said, isolation facility. And then, of course, the Kazungula Bridge project, illegal immigrants, commercial sex workers. Despite us not having reported a case so far, there's still a potential that those could introduce the disease into the area. Thank you so much.
Thank you very much, Dr. Kwadira, for such a lovely presentation. Very good to know personal experience from what has been happening in an important district like Chobe. We have been receiving a few questions on the chat box, but we will address them after the next speaker has also presented. So let me take this opportunity to move on, introduce our next speaker, who is Dr. Muthusi Mogatla. He's a family medicine physician and works as head of curative services for the Greater Gaborone DHMT. And he will go through the experiences related to his area. So please, Doctor.
Good day. As it's been said, my name is Dr. Mogatla. I'm from Greater Gaborone DHMT, which is mostly comprising of the capital city area and Mogoditsani area. Thank you so much. My co-presenter, Dr. Kwadira, has laid out some of the important aspects in terms of the structural components of the districts, the district layouts, in terms of how the district works or functions. To start off my presentation is that we all know that coronavirus is a new virus. The importance is that it's highly infectious and has a potential to overwhelm any local system. The background is that all our efforts in terms of COVID-19 are mostly directed by the Presidential Task Force, which directs all of us. And the focus has been more on prevention. And as a district, our strategy has been in line with that to be geared towards prevention efforts. We do have an existing rapid response team as a district, as outlined, that Dr. Kwadira has outlined some of the structures which are more or less similar throughout all our districts. We do have a rapid response team, which in the event of COVID, it has always been functioning. We always have outbreaks such as diarrhea outbreaks. So we had to redouble our efforts for the rapid response team. Our strategy was that we would involve, we formed 4 groups in our response or in our preparedness. One group was focusing on infection control. One group was focusing on community mobilization. One group was focusing on contact tracing, and one group was focusing on case management. In the initial response as a district, the infection control team focused more on training of staff, especially on the use of PPE. This was the time when we did not have the infection in the country, and we were in that preparatory mode. We also have our community mobilization team, which is mostly health promotion team. So the team focused or had divided the district such that we had 4 clusters, Tokweng, Gaborone North and South, and Mbodisani. And the team would go, the community mobilization would go in the community to do sensitization workshop, talk about case definition, other important aspects such as hand washing, social distancing, pretty much focusing on the community aspect, while infection control team was focusing on the healthcare workers getting ready. The other team, which was contact tracing team, was focusing on, as the disease evolved, we were having home quarantine from high-risk countries. They would do home visits, education on adherence for those who have been identified to have come from high-risk countries. And of course, the risk of the list for high-risk countries was always being updated. And so the contact tracing team was the one that was basically monitoring those who were on home quarantine at that time. This was when we did not have any cases locally, but we were now monitoring those who are coming from the high-risk countries. So our contact tracing team was always doing home visits on them. For the case management team, they were basically participating in the development of guidelines, which was basically spearheaded by the Ministry of Health, Public Health section. And then at that time, they also did a dissemination of such guidelines. Also, case management team was focusing on screening at the ports of entry. We have Tokweng border entry, and we have Sesretsakama International Airport. I should highlight that at the time when the there was the start of the pandemic, we did not have much resource from, say, for the port health officers who were at the points of entry. Therefore, we had to redirect our resources, as, for example, our nursing staff, so that they can be at the, they can start doing the screening at the points of entry. As the disease evolved, then we had those who were labeling as suspects of COVID-19. And this will be those who would have come and were mostly on home quarantine. The advice was that they do not have to come at that time. They don't have to come to our facilities. They were to call, and we would visit them at their homes. We at the time had 3 or so doctors who were trained and were dedicated to the response. We had 2 ambulances dedicated for the response. We were individually responding to each case of the suspects or the call as it came to the patient's respective homes. And then we were also those who identified were then taken for admission and testing. And we had identified one of our clinics, Block A clinic, where admission in the initial stages was done. But later on, we moved to Sekitumi Masire Teaching Hospital for other reasons, such as including space and the advent that if these patients were to deteriorate, we needed better support for them. Screening of patients, there was also, as the disease evolved, we noted that doing home visits to the individual patient was not being sustainable. So we then collaborated with our partners at Sekitumi Hospital, that there was a need to establish a screening center at the hospital, where we had transferred our suspected patients there. So we then had a screening clinic which been run there, which was then initially just had doctors operating it mostly for swabbing of patients. At the moment, we have about 6 nurses and 2 doctors per day from the DHMT. We also have the support from Sekitumi Teaching Hospital with 2 healthcare auxiliaries. And of note, we have done more than 1,000 of testing at the center. For those who have been for quarantine, we have for the longest been doing home quarantine, but as of mentioned earlier on by Dr. Khwadira, from the 25th, the ministry took a decision that everybody who is coming in our borders will go for mandatory facility quarantine, and there would be active monitoring of the patients. In the initial quarantine setup from around the 25th, at the point we had about 942 individuals under quarantine in 15 sites. These sites were mostly hotels. I had mentioned earlier on that we had about 3 doctors who were focusing solely on COVID response at the time. But with the advent of quarantine sites having so many individuals, it became apparent that the number would not be able to cater for the need. So we took a decision as a district that all our doctors should come on board and be able to take part in the activities of COVID-19. So we then have everybody being able to swabbing, and hence we then were able to test all these who were in quarantine at the moment, and those followed after. As an example, we have close to 250 individuals in quarantine at present in the different, mostly hotels, and a few who are on home quarantine. And I should also highlight that we also have a few who are, most of these quarantines, they are most of the first case, we have always been doing home-based, hospital-based isolation of confirmed cases. And this has been happening at Dumela Masire Teaching Hospital. As the disease evolved, at some point, there was a local transmission, and our teams who are on case management, obviously I should also highlight that the patients who are on isolation, because we have, I should also highlight here that as a district, we have, our COVID response has been more of a collaborative effort from different stakeholders. For example, our main primary referral hospital, which is Princess Marina, has been mostly in the initial stages being the ones who were taking care of our confirmed patients. Of course, with the UB School of Medicine, the medical department also taking the lead in terms of patient care. We also have private hospitals in the city, and these have also been encouraged to develop their own processes on patient care, and they have been coming at some level in terms of that. In terms of contact tracing, initially it was mostly done by the DHMT, and when a point reached where we were having a few cases, especially local transmission, then there was aggressive contact tracing again. I should also highlight that there was collaboration from both the Ministry of Health and Wellness, the combined efforts with our team from DHMT. The Ministry also brought on board one of our health partners, ACHAP, and an aggressive contact tracing was done at the point. Basically, also showing that our efforts have been from different contributions. We are testing truck drivers at the Wem border. As truck drivers have been identified as potentials in terms of having COVID infection in the country. This is because now we are at a point where we have not been having any local transmission, and therefore we had to look into our borders to see and to test. And of course, at the border right now, a team from the health district a team from ACHAP is actively testing, and a few cases have been identified through this exercise. One of the collaboration is with Botswana Police, who are actively escorting the truck drivers. This is important because as part of the SADC COVID-19 cross-border harmonization protocols, there has been an agreement between the neighboring countries that during this time of COVID, efforts should be made to not affect trade among ourselves. Therefore, Botswana Police is actively escorting, so especially locally, so that goods can still, trade can still be promoted. Also, we do community education as one of our achievements has been that there has been extensive general response to community education. And this is evidence as now people are being asked to live in the new normal era. We have now companies actively taking registers upon entry of premises, temperature check-ins, hand washing, sanitize. So if you go in the city, you'll be able to note that there has been some good response. These are just one of our efforts from earlier on, where there was extensive community education. However, there is need to have good monitoring initiatives from our city council. Recently, we noted that they were been hiring officers who are called COVID-19 scorpions, so that there could be monitoring of initiatives that are ongoing. We also, as a district, do periodic and random spot checks on businesses in the community, so that we can see and monitor the response. Our challenge, I think our main challenge is not listed there, is that COVID-19 is not yet over, but with the lockdown and now over, people are now going back to their usual or their routine life. So we are losing some of the support which we have had in terms of partners, in terms of the response. But the response, I mean, the pandemic is not yet over. At some point when there are delay in some results issuing, but this has been sorted by having Botswana Harvard partnership, whereby government have roped in other laboratories, facilities to try and speed up that process. There are some dedicated vehicles which are able to transport specimens and results. Also a decision was taken that Tlokwe border was being congested at some point. Therefore, we needed to create a dry port within the city at fairgrounds. Obviously, we have challenges where there is need for provision of toilets, bathing facilities, environmental sanitation, but these have been challenges which are taken care of course, with the Office of the District Commissioner and all other stakeholders. And a team from DHMT and Bouquet are on the ground to monitor and facilitate these challenges. The truck drivers, of course, obviously, there are also some bit of lack of cooperation at some time, as they would wish to have to be free, but we are basically guiding them and making them to be under escort all the time. So that sometimes creates a challenge. Recently, we undertook an exercise of community testing Basically, this was following social media reports of some cases which were potentially arising from our borders. And then they were traced in one of our village catchment area, which is Mogoditsani. Therefore, a decision by the Presidential Task Force was taken that we should go and do testing, contact tracing by testing households. The target was that we would test 1,600 households, which was to translate to about close to 6,000 individuals. We collaborated with our partners still, Ministry of Health. We were led by a Ministry of Health Public Health team. In the community testing, the methodology was that we formed 14 teams of 4 members. There was systematic sampling of every second household and every second compound, which have been randomly selected from the enumeration areas. These enumeration areas were basically from Botswana demarcations. And the outcome is that we were successful to, even though we were to do it in 3 to 4 days, we ended up doing the exercise in about 6 days. We tested about 2,506 households and a total of 4,840 individuals. One of the challenges which we noted was that we did the exercise during the day. Therefore, some people had gone to work, and hence sometimes we found that there were less individuals in the households. We are at a point in the pandemic where perhaps there's containment of cases, but there's active surveillance and early case identification, especially at the border, and we are still doing mandatory quarantine and active monitoring. In terms of capacity building, I had earlier on touched on this, that we had 3 doctors who were trained and deployed for COVID. Now we have since now having every doctor in the district, except those who are on medically exempted, were able to participate in COVID activities such as specimen collection, swabbing of patients. And the plan going forward is to have our nursing counterparts, such as even ACAs, also being ready to do this important exercise of specimen collection. We are also, as a district, thinking about what could be the worst case scenario as we are still doing quarantine. This is basically informed from our previous experience from the cases we have had. Scenario 1 would be when we are having a very strict definition. For every case, we are looking at having 50 or to 300 contacts. And then for scenario 2 is when we are having a less strict definition, where we are now even including casual contacts of the environment where the patient has been, and we can easily have 1,000 contacts. And all these, if we continue with the mandatory quarantine, we need to be taking care of. In the worst case scenario, obviously, it means that the country will go back to lockdown, and then, of course, the direction will still get it from the task force, the command center, the Ministry of Health, where there will be mobilization of resources such as supplies, PPE. And of course, our infection control section will be the one that's spearheading our efforts in this line. In terms of contact tracing, we are to train 4,000 contact tracers, so that this would mostly be like our Chobe, but we train this group. They are not all engaged now, but they will be be trained and then continue with their other duties. If we need them, we can quickly call them and do contact tracing in the shortest time possible. Our partners also have shown interest in participating in this contact tracing exercise, such as Archer, Bouquet, HVHI 360, Boomi, and or any others, such as UB Public Health Program. In terms of case management preparedness, we have looked into public health facility institutions, mapped which ones could be ready, could be available, and obviously sensitize them on the possible use of their area should the need arise. And also we have had help from our UB School of Medicine in manning of the quarantine site in the past. And we therefore will also be looking out for them to also help us in that exercise. Thank you so much.
Thank you very much, Dr. Mohatla, for that detailed and lovely presentation. As the presentation has gone, there have been questions all popping in. So I wanted us to address those. So I think if you just access my PC. Yes. I'll let the presenters to share a few comments on some of the questions that have come in first before I let others ask questions. There was a question to Dr. Kwadira, whether how come you couldn't do more than one cycle daily, and if those 27 individual clients who are currently under quarantine have been actually tested before they started. And also another question was clarification on the number of beds that could be available, but you clarified on that already. And the third question was if partial payment fees are unique in Chobe or not.
I'll start with the one about why not do 4 cycles. You may recall that from the presentation I said we can only hold 80 trucks at a time. So that is one limiting factor. And then the other thing is you cannot get all the samples at the same time. Trucks come one by one. So what we have decided is that at the end of the day, that's when we take all the samples and go take them for testing. And at that time, we can only take 80 trucks. But the other limiting factor, if we had more space, is also staff. We are running with 2 members of staff, so they're only working in the night. During the day, they sleep. So that is another factor. Then the other question was about whether the 50% payment is for Chobe. It's for the whole country. So I think last week it came out that the government took the decision to make sure that people who are coming into the country pay 50%. So it's not only a special instance to Chobe. Then the other thing about testing, the current guide is that you are quarantined and you are tested at day 10. So we are still sticking to that. Those that we test immediately and let them go are only the trackers.
Thank you very much for that clarification. We will move on with the questions that Dr. Mohatla also received. There was a question on those who actually test positive and then get repatriated, whether they are given their test results in writing or a certificate or something, or if they are kept separate from other trainees. And also when it comes to those teams that have been included in as part of community testing and contact tracing. Are social workers also included? There was also a question on whether hotels are using commercial rates or concessionary rates. I think I'll stop there before we continue.
Okay, the question is about whether the hotels use commercial rates or not. I'm not sure about the exact amount that the rate, in terms of the rate, but I know there is a negotiation between Ministry of Health and the different hotels about the rates. In terms of the social workers, if they were involved as being part of the testing, we did not have the social workers as part of us during the exercise, but obviously they were involved with the giving of food hampers in the different communities. And the other question was whether the truck drivers are given the certificate. So for every person who's tested, their results are printed, and they should receive a copy of the results to show for their records. There's also a question whether was it ACHAP or BUMI who did contact tracing. When there was aggressive contact tracing, to my recollection, it was ACHAP who were involved, but obviously BUMI also were involved to some level, but the ministry had engaged more of ACHAP when there was contact tracing, especially in the village of Chobe for contact tracing.
Right. And then another question was the results of the oncology testing. The results. Yeah.
The results of the
testing.
The results, the exercise has been completed. We had done testing for 4,800 individuals, but the results have not yet been all released for all of them. Initially, when we completed 900 have been resulted at the time.
Yes. Thank you, Doc. I think Dr. Jibril wanted to pose a question directly, so please go ahead.
Thank you very much. I mean, I was just, last week, I think the issue of the thermometers that I think this is a general question, actually. I don't know how it was addressed. I know the
any other
said,
questions before we close? He's talking. Oh, Dr. Jibril, we cannot hear you.
Oh, really? Can you hear me now? Hello? Yes. Hello? Hello?
I think their mic is having, or their speakers, they do have a problem, Dr. Jibril.
It's okay, Dr. Jibril, you can go.
No, it's okay. It's okay. If you can't hear me, that's fine. I can comment next week. That's fine.
Now we can hear you, Dr. Jibril. Go ahead.
You can hear me? Okay.
No.
All right, sir. So, I mean, like I said, it's gone off. It's a general question about the thermometers. I know last week the presenter mentioned that the the thermometers needed calibration. And I just wondered, you know, we're doing these things in good faith. We are just, and I wonder who actually looks at these results that are recorded in all the shops. But who does the calibration? Because I don't think that the Botswana, the BB, the standard of, I don't know what they're called, those that are in charge of the standard can go around all these shops and calibrate the thermometers. Now, if we are really serious about using them as screening, we need to have a way of really getting these things sorted out. So I just wondered whether the ministry or the task force is actually doing anything about that. Thank you. Over.
Thanks, Dr. Jibril. I think that's a good point. I rather take it as a comment rather than as a question, but currently BOPS is the one that is mandated to do the calibration. However, we do acknowledge that they do not have the capacity to calibrate all the thermometers that are currently in use in the country. So that remains a challenge. But at facility level, we do have, within the health space, we have biomedical engineers who are willing to assist in that regard. However, because it's just a new thing, you know, some of these thermometers are calibrated. I don't know the exact timing, but probably it's, I'm thinking it's 3 months or 6 months. So most of this have not gone beyond that period. So we haven't gotten to the point where you have to calibrate.
Oh, thank you. Thank you, Kwadira.
Thank you for that good question, for the answer. I think in the interest of time, we will have to wrap up. Start thanking Dr. Kwadira and Dr. Mohatle for such informative presentations. We've been curious to know what is really happening out there in the districts. And we have gotten good insight into that. We'd like to thank you all for coming and for also availing your available time. We thank you, the audience, also for having time to participate. Please do take part on the survey that will be sent to you afterwards, and we will announce on when the next webinar will be. So thank you all, and have a nice afternoon.